Good afternoon and welcome everybody to our Vulgan afternoon meeting. It's a pleasure for me to share this meeting together with my two co-chairs, which I will present when they have their presentations. The meeting is about local wound conditions, local wound treatment, and I will have a first introduction into this with the question, how's the local impact of non-healing wounds, followed by two more specific presentations on Vulgan and also on the wound conditions. This symposium is supported by Vulgan, is obvious, and I don't have any other interest with respect to the presentation. But I'm keen to discuss with you and to listen to the other talks about this new component in the treatment of chronic wounds. My presentation will introduce you into this by providing some interest and knowledge about wound entities, wound healing, the need for wound management, some standards, and also consideration how and if we should make use of the innovation pipeline in wounds. Starting again with the question which wounds we are talking about, and you know that there are many different perceptions on this also depending on where you're working. Probably you're not working in such a center which was maybe the standard in the 15th century when wounds mostly meant wounds that were damaging because it was artificial and followed war or any other terrible things. Today still we have acute wounds of different sizes which are healing in a small period of time, which do not deserve further attention except of keeping them as clean as possible. And then we have those delayed wounds which have a prolonged healing time, which may be infected, like this surgical wound you see in the picture. But we are talking today about the stagnating wound, the chronic wound, which doesn't show signs of healing for a period of time, but also which is based on a pathology of the tissue, not deriving from previously healthy skin. And this is a typical 55-year-old female patient with type 1 diabetes and a non-healing wound, as you see. And maybe it's a little infected or sludge on this, and the cause has been deep inflammation of the skin in this case. So such wounds are what you're familiar with. And the challenge is that these wounds do not are directly referred to us as experts, but in a previous study regarding community ulcers, we saw that patients on average who were treated in the community had an open wound for more than 2 years in the Hamburg area, and the disease duration, including the underlying condition, was more than 8 years, as you can see. So obviously there has not been a precise and immediate intervention in these patients. And I think this is what is the risk for all patients having wounds like these, chronic wounds that you're familiar with. They are aged, they are multimorbid, they have multiple etiologies, a high patient burden, also high economic burden, and they missed to be treated at an early time point so that these wounds could escalate. Regarding the pathogenesis and then further look into the physiology of the wounds, you know that the final result, tissue damage, can derive from many different conditions, both vascular conditions, inflammatory conditions, those being of physical origin like chronic pressure. We need to look after this before we really start intervening. And just focusing on leg ulcers in the next slides, it's for sure that the underlying cause needs to be identified before going into details, and this by probability means that most of the wounds that we can expect are of vascular origin, but there's a marked number of wounds which also have very different underlying condition and need to be treated differently. And so in such a situation, we need to make sure that we are on the right track and haven't missed another diagnosis. Regarding the local impact of such wounds, there is a rich and very complex pathophysiology which may be a focus in the next presentations, but just to remind you that also acute healing doesn't happen all of a sudden, but in a series of events which are when described like fibroblast expansion and differentiation, proliferation, which is lacking in the chronic wound. Here you see the comparison, acute healing, chronic healing. There's a delay in this and in many other cellular components also, like in the keratinocytes. But some cells are dominant, like the leukocytes, which are more in number in most chronic wounds and can put damage, also macrophages. And finally, there's regarding the cell component, there's a deficit in angiogenesis in chronic wounds compared to acute wounds. There's damage in chronic wounds based on reactive oxygen species, MMPs, and also maybe bacteria, which may be damaging to the wound as well. So it's a series of events happening, and some of the cellular components of the different specialized cells are key. For example, the leukocytes, which lead to an elimination of damaging components, the complement coming from proteins, the lymphocytes leading to immune responses, the monocytes differentiating into macrophages once leaving the vessels and then contributing distinctly to the elimination of microbes, but many other factors which we will learn about in the next presentation, and fibroblast producing extracellular matrix, which is a basis of repair. So these cells are important. None is more important than the other, and it's the concert between them which makes wounds heal or not. And they are signaling not just in direct touch, which we call adhesion, but also by signaling, by communicating with a large number of factors, which I don't go into detail, but there's plenty of, and we will discuss this later. I just want to remind and summarize the pathophysiology of the non-healing wound on the right compared to the physiological wound. That on the one hand, we have the risk of infection, local infection. We have high proliferative epidermis, but no signs of complete epithelialization. We have persistent inflammation. It's a key problem to deal with inflamed, not just infected wounds. We have a senescence of fibroblasts which get lazy enough. We have impaired angiogenesis and fibrin cuffs around the vessels. And finally, the MMPs elevated and disbalanced. So this is a series of problems which sometimes interact and which we need to identify in those wounds. And wound healing then happens if those problems are overcome in different stages or healing phases. We know those wonderful pictures when wounds start to granulate or to develop epithelium. This is what we want in our wounds. And we are realistic enough to know that 100% wound healing is not the only goal in a wound treatment of chronic wounds, but we need to be modest and follow several steps. So one interim's goal could be just to have a clean wound, to have readiness to graft, to be able to debride, and across all those phases, as you know, there's the need for infection control, exudate control, and pain control regarding the patient perspective. So this is a lot of work that we have to do, and so there are specific needs in wound management. We need to be comprehensive, thinking largely, and we also need to include the patient in this large thinking, because in many ways wounds are very individualistic and specific, and the fingerprint of a patient can also well be reflected by the way the wound extends and he feels with his wound condition. And we should be realistic to also include the patient needs and the patient potential goals of treatment into our doing, knowing that complete wound healing is a very important goal, and we know this from large studies that we have done in Germany on chronic wounds. Almost all patients say, yes, of course, the wound should heal, but beside of this, there's a large series of other important goals like less pain, also no exudation, no bad odor from the wound, having no fear of disease progress, or be less burdened by physician and clinic appointments. Very remarkable. We always were disappointed with this answer because we thought we are needed in all cases, and the more they see us, the better. But patients tend to want to be independent, of course, and want to be driving their development themselves. So the note here in the conclusion is patients have a large number of needs which need to be identified as single treatment goals. We can make more of it when we define the goal, identify the need, and then try to achieve the goal. Regarding the approaches that we have in chronic wound healing, you will surely agree with me that there need to be standards both in diagnostics and treatments. And this is a typical case, really also scaring case, where no standards, no specific approaches have been driven. This was a patient I saw in our intensive care unit at the University Medical Center in Hamburg, in Germany. And this patient was admitted to hospital with a diagnosis, chronic venous ulcer, and you immediately see this is the foot, the back part of it, that this is no venous ulcer, it's not even a leg ulcer, but a foot ulcer, and a massive one with massive edema. And you don't need much time to see that this is not a primary vascular wound. This was the regular one. It was a severe vasculitis, and the patient was admitted to intensive care because there was acute kidney failure. So when at the earlier time point, one of the community physicians of the GPs would have realized that there's more need for action in these wounds, the patients could have avoided this severe case and barely survived this whole issue here. So regarding local impact, we need to identify what and get as much information from the wound as we can, and then there can be many different options, like I have shown before, with a large proportion of vascular, but even many other forms of ulcers. Hundreds of options possible. And now, having done this, having a clear concept of treatment, of treating underlying conditions, then we can move to the wound and check how the wound condition is. And it's very helpful to also follow a standard here and a systematic approach. And Yuma has for long positioned a paper saying that the time scheme may be of favor, and you may know those points. And I quickly go through this because it can be helpful. But nevertheless, regardless how you do it, it makes sense to accurately follow different steps in the wound investigation. One being looking at the tissue, which here, as you can see, includes fibrin, it includes epithelium here, granulation in tiny areas, but especially necrosis, and this needs to be described and conclusions being drawn. But this is just the tissue in the wound. Infection or inflammation means to regard the wound and check if there's a risk for this. And as you can see easily, there's erythema around the wound, which is a sign of inflammation. If you touch it, it's very painful. This is what you cannot derive from the photo, of course. There's desquamation, that there has been probably fluid here so that the skin desquames. Regarding moisture imbalance, you see that there's a balanced exudate, of course depending on the time point when you remove the wound dressing, but there's also xerotic skin around in these areas here, so it's not really balanced and needs further consideration. And finally, as you know, time also includes the wound edges, which are very helpful to investigate because acute and active processes can better be seen here at the edges than in the middle where the process has already been done. And what you can see here is, on the one hand, necrotic margins, like here, there's necrosis, and there are also inflamed areas here, which show that there's activity in this wound, which, by the way, is what? What do you guess? Dermatologists should know. Pyoderma, yes, BB knows it, yeah. Pyoderma gangrenosum was the diagnosis here. So, following this and being systematic in diagnostics, of course, treatment is the next step. And as you know, we cannot standardize wound treatment as we could with drug treatment. If we define the drugs to be uptaken, then there is some standard in it, and it's repeated in dose and in the way of application. And wound treatment starts with variations in the way bandages are positioned, and continues with many more variations than in drug treatment. And so in reality, we need to be very flexible, standardized, but also working in a personalized way. And this is just a snapshot on 20 wounds in 1 or 2 days of our wound clinic. And in these 20 wounds, we used 12 different wound dressings, because this followed the conditions and the needs in those patients. And the criteria for choosing different ones rather than having one unique are mentioned here, from wound type and pain status, wound edges, exudation. They all contribute to decisions which then are individual, and doing so we have predictors of healing outcomes. One, we find the best combination. But nevertheless, there is the need for standards, in that we are aware of the evidence about what we know and what has been shown to be effective in defined wound conditions. And this is a recent meta-review, a systematic review on systematic reviews of wound outcomes from the Netherlands. Maybe one of the authors is in the room, because they are all from Amsterdam. I would have loved to have them here, because it's a very nice systematic review, and it summarizes our overall knowledge, which in single cases may be divergent from what we see in a patient, but as you know, there is evidence for more than we expect in wound care, and we should keep this in our mind. And finally, we should be aware that there is a pipeline of innovative substances. We need to be critical with them, because they need to provide evidence and the proof of concept. But we know that new upcoming technologies with proven evidence have a special place once they are superior, and then we should also dare to invest more and pay more if they prove to be superior to other options. And this is what sometimes is lacking, especially from the payer perspective. And I like to show this scheme for this. This is schematic, and we published this as an example in The Lancet some years ago, which shows that if we just look at the wound treated properly but traditionally, without risking any further, let's say, additional treatment, where mostly the wounds keep like this for years. But if we use advanced technology, even if there are higher costs initially, this can work out in lower costs and a return on invest on the long term. And this really happens, and examples for this are compression treatment. The lifetime costs for compression treatment are lower than leaving out compression in patients with venous leg ulcers. Topical negative pressure, some other treatments like electrostimulation, tissue engineering, beta-glucan, they also are a sort of invest at the beginning in order to break through the stagnation of the wound and get into a more active phase. So the message here, we need to invest in rapid transfer from wound stagnation to proliferation once we want to be successful. And the last point, which has to do with this, is that we need to be early and alert when patients come with upcoming wounds or with conditions in risk or at risk of getting a wound, like severe edema or like arterial occlusive disease, which may not result in a wound yet, but the risk is there. And then at this point, we need to react early. And this early intervention, compared to just sleeping and waiting too long, is associated with saving the patient from higher costs and the payers, but also with saving the disease burden to the patients if we are early enough. And so the message here, there are avoidable costs upcoming which are raised by late intervention. Don't lose the opportunity to react early. So coming together and landing up with my title, The Local Impact of Non-Healing Wounds, you have seen the many facets here, and I guess that you would agree with most of this. The rest is for discussion, and I propose that we have a discussion at the very end so that we follow the next two presentations and then have a panel here. So at this point, thank you for your attention.